morning. There's really a lot that we have to cover, and I wanted to start out by talking about what we are going to be doing today. Yesterday we had a really excellent introduction about the anatomy of the nervous system, and also excellent presentations about this broad spectrum of the neuroimmunologic disorders. For the next couple days, we're going to be focusing in on the symptoms that are caused by these neuroimmunologic disorders and the symptom management strategies for treating those symptoms, which we have a tremendous commitment to in the association and trying to get this information out to all of you. So we're really excited about the presentations that are going to be made in the next couple days. I had a thought last night, and I'm going to, I had a little bit of concern about doing this, but I think the value of doing it far outweighs my concerns about sensitivity about it. There could be people in the room who have either optic neuritis, DEVIX, ADEM, or recurrent TM who don't know each other, who would probably love to be able to talk to somebody else who has your condition. So I'm not going to ask you to raise your hand and identify your disease. Here's what I'm going to suggest. If you have optic neuritis or DEVIX disease, at the first break, why don't you go over to this corner of the room if you're interested in meeting somebody else. If you have ADEM, why don't you go to this corner of the room. Have I missed any? What was it? Was optic neuritis, DEVIX, ADEM. If you have recurrent TM, go to the back of the room. If you're not interested in doing that, go to the bathroom. But if you're interested in meeting someone, I think that would facilitate a way of doing that. Otherwise, you're not going to be able to find each other. Chitra? And with that, we will... if you don't know the answer to that question, go to the bathroom. That's a really complicated question.
Thank you. Okay, I'd like to introduce Dr. Barbara deLateur. She is a professor in the Department of Physical Medicine and Rehab and has had a long-standing clinical and research interest in gait and biomechanics. And she's going to talk to us today about rehabilitation in transverse myelitis. Thank you.
Thank you, Chitra. Can you hear me? Good. This is going to be a conceptually organized presentation. It might sound a little preachy, and if it does, I know I'm preaching to the choir. I should be saying these things to a room full of physicians, especially rehabilitation physicians. Okay. But you're here, and they're not. So you can go carry the word to others. So we'll organize this presentation around goals, a guiding principle that's woven throughout all of rehabilitation, and then some strategies and tactics. How many strategies depends upon whether you're a lumper or a splitter, and tactics are legion. But many people, I think, who do rehabilitation just focus on the tactics, and so it becomes a laundry list, and sometimes they don't really think of what it is they're doing or trying to do. In Patton, there's a great scene where Patton comes to North Africa. Everything is a mess, just an absolute mess. And he comes upon a soldier. and the soldier's curled up in a corner. And he says, "Soldier, stand up. What in the hell you think you're trying to do there?" And he stands up and salutes and says, "Just trying to get some rest." He said, "Get back down there. You're the only one around here and who knows what he's trying to do." So, the goals. What are we trying to do? The first goal, again, in my view, is preservation or restoration of optimal function. Optimal function. Here's an important one that we don't talk about enough. This is extremely important at all ages, but especially in a geriatric population, in which I spend perhaps half of my working time. I am at Bayview. The scriptures say, when you were young, you went where you wanted to go. And now that you are old, they will bind your hands and take you where you do not wish to go. Bind your hands, restraints. Individual autonomy. So the doctor is not the boss. The old-fashioned sayings, doctor's orders. Well, that may be technically true. In the hospital, you have to write orders because that's how things go. But individual autonomy is extremely important. And finally, preservation or restoration of the patient's role or a new role, or whatever the patient desires as a role in the family and society. The principle. What is the principle that goes through this? And this is rarely spoken of by people in rehabilitation: anticipatory management. It's absolutely true that no two patients are alike. Even if you have twins with the same disorder, they're not going to be exactly alike. But there are patterns. There are things that we can anticipate. We don't have to be constantly hit upside the head by surprises. If someone gets a pressure sore, oh, how did that happen? So you can anticipate what can happen. But who is the manager? Who is the manager? Anticipatory management. Dr. Wegner is going to talk to you the next presentation about the patient as manager. I would submit to you that early on, the physician and the rest of the team have a very large role. Physician, nurses, and all of the team have a large role. But the further out you get, the more the manager is the patient or the family, depending upon the age and the cognitive abilities. So anticipatory management, but empowerment of the patient. This is what I am about. Empowerment of the patient to take control of his or her own life. We supply him with the tools. I will say, think of me like a technical consultant. A lawyer speaks of clients. A vocational counselor speaks of clients. I am a client of my tax accountant. And I would do well to listen to him. I know of people, he can't, of course, mention their names, who didn't take his advice and all of a sudden had a $3 million tax burden that they cannot pay. And it had to do with mutual funds, it had to do with tax shelters. So one does well to listen to one's technical consultant, but the patient and family and spouse set the goal. The real manager is the patient, and we are, as physicians, are your technical consultants. As I say, too bad that there isn't a room of physiatrists here to listen to that. Rehabilitative strategies. Again, how many? Depends upon whether you're a lumper or a splitter. Primary prevention. Who thinks of that as rehabilitation? Yet, it is not the best rehabilitation, prevention. How many here have ever heard of Enders, Weller, and Robbins? Nobody here has heard. How many have heard of Salk and Sabin? Everybody. Without the work in pathology and pathophysiology of Enders, Weller, and Robbins, there would be no Salk or Sabin vaccine. So people working in the basics to help prevent these disorders are doing a lot for rehabilitation. If it weren't for Enders, Weller, and Robbins, then when we go to our physical medicine rehabilitation conferences, we would be looking at shiny new iron lungs and ventilators of various sorts. We still have to look at them for many people with these rare neuroimmunologic disorders. I've spent a lot of my professional life in traumatic spinal cord injury. And there, great strides have been made in prevention. We're not where we need to be. There are still spinal cord injuries. Gunshot wounds. That's the largest number of patients with spinal cord injury that I see, are gunshot wounds. But we're not there yet. We'll get there. Reduction of the pathology to a minimum. Yesterday, you heard about the importance of early diagnosis and early treatment, so that one may have a certain condition, but it's different from a spinal cord injury that tends, in the overwhelming number of cases, to be level. There may be additional lesions that come, additional lesions disseminated in time and in space. And it's important to treat those early to reduce the pathophysiologic condition to a minimum. These strategies are usually implied. They're the first explicit rehabilitative strategy is prevention of secondary complications. We learned a great deal from spinal cord injury management, or lack thereof. President Garfield, when he was shot, lived 8 months as a person with a spinal cord injury. Every complication in the book, because they didn't know what to do with it. He didn't die of spinal cord injury. He died of the secondary complications. And such things as prevention of pressure sores, we all know about these things, deterioration of the upper tracts in the genitourinary system, depression, all of these things. Now, enhancement of the function of the affected systems. What do I mean by that? Well, I'll contrast it with a couple of other strategies. Contrast it with compensatory rehabilitation. Okay. Rehabilitation is usually thought of as picking up the pieces. You have some kind of stable lesion. Okay, you're going to do the best you can to live the best kind of life you can, but what you seize is what you get. Here we've learned a lot from patients with stroke. We used to think and used to tell our patients who had a stroke that everything that you're going to get back spontaneously, whatever that means. I guess that if you put the patient in a closet for 6 months, certain things would be happening spontaneously regardless of what you did. And the lion's share of that would occur in the first 3 months. But what you got was what you got, and there was nothing you could do about it. In fact, while I was still a student at the University of Washington, a famous neurologist, he wasn't famous then, he's famous now, I won't mention his name, but he said to me, shaking his finger at me as he did so, knowing I was going into rehabilitation, he said, "There is nothing whatsoever you can do to the periphery that has any effect whatsoever on the central nervous system." Think of that. All you can do is compensatory rehab, or and one time I still in the state of Washington, called this doctor in Olympia who had the power to approve or disapprove the rehabilitation programs we proposed. And I called to ask him why it was he wouldn't pay for outpatient occupational therapy. And he said, and I quote, "You're lucky we pay for anything, Cookie." That's Dr. Cookie. You know. He said, "I wish to God you'd put them all in the nursing home in the first place." This is a man with an MD after his name. Now, he hadn't seen a patient for a long time. He sat and shuffled papers. He said, "You don't do anything for them. Might make them a little bit more comfortable, but you don't do anything for them." Well, in fact, we do. And the work of Nudo in non-human primates and the work of Taub at the University of Alabama, Birmingham, has shown people as far out from their stroke as 12 years by this constraint-induced movement program got back significant function. We all thought that was impossible. Remember the old joke, the difficult we do right away, the impossible takes a little longer. And when people think of constraint-induced movement programs, they think about the better hand being constrained from participating. So it might be held behind their back, might be put in a splint. But there's another constraint. It's constraining the affected limb to do purposeful activities for 6 hours a day. 6 hours a day. How about 3? Well, there was a study recently, and 3 hours is not as good as 6. Who's going to pay for 6 hours a day? But I would like to propose, I'm not seeing Dr. Kerr, but that's all right, I know where he lives, that when we investigate some of these new drugs, that we do a 2x2 study. Drug, placebo, exercise, sham exercise, and see. I would predict that those who do the right kind of exercise combined with the drugs are going to make more progress. Everybody wants to be cured. Who wants to be rehabilitated? No? You want to have as much improvement as you possibly can. And things that we thought were impossible are possible. I saw a patient at Johns Hopkins Bayview last week that who did something, and he was I think late 70s, and he'd done something ever since he was 18 that anyone who knew anything about gait would say it was impossible. It's like the bumblebee. Every aeronautical engineer will tell you it's impossible that they could fly. Okay? But bumblebees can't read, so they've never read those reports, and so they fly. This man had an amputation due to a tumor at age 18. And he uses one crutch. If he had used it as a crutch, it's true, it would have been impossible for him to walk without a prosthesis, just one crutch used as a crutch. But he didn't use it as a crutch, he used it as a limb. He held it very tightly into his body and was very strong in that arm, and walked with it as though it were a peg leg. Stairs, goes everywhere. You know, and when we came to see him, he said, "I didn't come here for walking. The problem is my blood pressure," and there was something else. So I said to the people who asked me to see him, he's here for his blood pressure and whatever was the other thing. We weren't going to, quote, fix this and give him an artificial limb because he said that'd just be in my way. So, and it would have. enhancement of the function of the unaffected systems, and that greatly overlaps with the compensatory tactics. Now, I'm here to tell you that I think in this healthcare system, and I'll try to avoid any political statements, but unless my id gets away from me, in this current system, the emphasis is on compensatory rehabilitation and how fast can you get the patient out of the hospital, treat and street, as we say, so that you can do some transfers, fine. Don't think about walking. If you have a stroke or hemiplegia from any cause, just use the other hand. Now, compensatory tactics can be great things, but in this case, they can be made the enemy of the enhancement of the function of the affected systems. So one of my jobs, I think, is as advocate for people who are living with disabilities to any degree. Yes, compensate, and patients are often very good at that, and some of the things they can accomplish are astonishing. You saw a video yesterday of a patient in Seattle. That's where I come from, and I didn't recognize him because it's been 10 years since I've been gone. But we trained people to use a sip and puff Morse code interface. We had one man who was a C4, who was living with a C4 tetraplegia. All he could do with his arms, he could shrug his shoulders, he could talk, he could inhale, had a weak cough, and he learned to type and could type over 40 words a minute with a sip and puff Morse code interface. Okay, and the last time I had checked, he had been back to work as a consulting engineer for 10 years. So compensatory tactics don't minimize those, and the assistive technology is getting better and better, but our use of it and our access to it is not better and better. So we are still not doing, maybe I shouldn't say this, but we're not doing in rehab at Hopkins some of the things that we did in Harborview 10 and 20 years ago. The special learning techniques, I will just tell you about one of them. I will tell you about information feedback. Dr. Wegner will tell you more. Information feedback is extremely important in rehabilitation. It's important in everything. Okay, information feedback has two roles: the cue value and the reward value. And if you don't think information feedback can motivate people, then you should see all these grown men on the stock market floor when a chart goes up or down. They're clapping, they're yelling, they're, or bemoaning what's happened. Information feedback is very important. So just seeing some graph that you want to improve going up is a very powerful reinforcer, very powerful reward. In my view, the cue value may be even more important. It certainly is for any kind of a motor skill. Everybody knows who Bill Gates is, world's richest man, Microsoft founder. Okay, now, well, the stock market goes up and down, how many billions he has, but he has got a lot of billions. Now, suppose he offered me one of those billions, heck, two, to drive from the front of this hotel to my apartment on Fells Point, blindfolded. Doesn't matter how many billions, how great the reward is. I couldn't do it. I'd have a wreck the first thing. Okay, so with motor skills, the cue value, so that you're constantly modifying what you do is very, very important. But they're both important, reward value and cue value. So you look at the people on the Olympics, the performances. I don't know if you saw any of the reruns last night or this morning, but the astonishing perfection of Carly Peterson on this. So that the constant cue value is very, very important. So when you're learning something new, and this is important as we go forward, as we try to recover function with the use of drugs, with the use of exercise. This information feedback will be very, very important. So, in summary then, we have at least 3 goals: preservation or restoration of function, preserving or restoring the autonomy of the person, and preserving or restoring the role of participation in the community as desired by the patient. The principle of anticipatory management: who is the manager? Early, the rehabilitative team. The further out you get, the more the patient is the manager and must be empowered to do so. And then a number of strategies and tactics that can be applied. I think we have 1 minute if there's a question or a comment. Yes, please.
Could you comment on Christopher Reeve's personal success?
Yeah, I would comment that there's several things. A, never give up, or the difficult we do right away. The impossible takes a little longer. Bumblebees do fly, but it's also what can be done if you have enough resources. And it's extremely frustrating to me of who gets the resources. So that those who have a lot can achieve a lot. Thank you all very much. Oh, sorry, another.
Real quick, it's a dumb question, but when
There are no dumb questions. I can't vouch for my answer, but CUE, Q. Like Q, oh, thank you very much. No, it's not a dumb question. You might have thought of the letter Q. No, it's CUE, like cueing you that you did this wrong, cueing you better step on the brakes or that car is going to hit you. You're going to turn off the road. You're going to hit that little old lady. Okay. Hate it when that happens.